Welcome everyone. Today we are going to discuss an important problem that affects millions of people globally. Tuberculosis treatment update. Did you know that nearly 10 million people affected by tuberculosis every year globally? It's a staggering statistics, and that's why to stay up to date with the various treatment options is crucial. Over the past 10 years, we have had lot of changes that has been incorporated not only in the diagnosis of tuberculosis but also in the treatment. For example, we have daily regime over thrice a week regime, then we have fixed drug combination that is given as per the weight bank. We have gene expert, drug sensitivity testing. Then we had also incorporated newer and more effective drugs like bedaquiline and delamine. However, few challenges like emergence of drug-resistant strain and combination of TB and HIV posed a newer challenge. Let's get started and explore the various treatment updates available for the tuberculosis. So in this part, we are going to cover about the drug-sensitive tuberculosis and its treatment. Tuberculosis is the one disease that we consider as the barometer of socio-economic development of any country. Many developed countries has nearly eliminated the disease by raising their standards of living. India is contributing to 25% of new cases globally, and it is crucial that the healthcare personnel are equipped with proper knowledge and skill needed to diagnose and treat the TB. And this is particularly very important, especially when nation is aiming to eliminate TB by 2025. World or the rest of the world, the target has been set by 2030, but by us it is in 2025. So it is very crucial that we stay up to date so that we can have a high index of suspicion and we can diagnose and treat tuberculosis, or we can refer it to the health facility where it can be better managed. Now pause for a while and think about what could be the objective of tuberculosis treatment. Not only tuberculosis treatment but any infectious disease, what we are aiming for, what will be our objective. So the first is the decreased pool of infection. For any infectious disease, it may be malaria, it may be typhoid, or it may be a cholera. So the first and foremost important thing is that we want to reduce the pool of infection so that we can prevent the other infections, other patients. So by rendering patient non-infectious, we are blocking the chain of transmission and we are preventing the further spread of disease. So this is very important first objective. Second is the relapse-free cure. By giving a proper treatment and proper follow-up, by ensuring that the patient is completing treatment, we will achieve a relapse-free cure. So even it is true for the malaria, typhoid also, that we don't want the relapse, recurrence. So that is why we are treating, or in the way we are treating. So it decreases the case fatality and morbidity, which is very true for tuberculosis. It's a chronic disease. Patient may develop drug resistance or other complication and patient may die. So relapse-free cure is the second objective. Third one is the prevent development of drug resistance. Third objective is also very important as far as the tuberculosis is concerned, because before we were treating patient with the help of the first line drug. Then eventually the resistance started and we have to add the other drugs, newer drugs. So the prevention of resistance is very important, and once the resistance develop, we have to add the other drug. The drug might have toxicity, so we have to monitor patient for the toxicity, and the duration of the treatment is also increased and patients suffer, and the transmission of such resistant strain to other general population. So that is why it is very much important. Now let us look at the statistics regarding the India's share of tuberculosis. So as per this data, around 1 crore or 10 million people affected by tuberculosis globally per year, 127 per 1 lakh population, and India is contributing to around 25% of globally. Around 10 million people affected, 127 per 1 lakh population, of which India is contributing to 25% of cases around, which is 188 per 1 lakh populations. These are the newer cases. So in terms of the total number, around 25 to 27 lakh cases per year. This many cases happening in India every year. And if we consider the death, it is also around 38 to 40% death. So deaths are also high. So India's contribution is very high. That is why we are worried, and that is why we are determined to eliminate tuberculosis by the end of 2025. And the targets for the elimination that are set are 45 new cases per 1 lakh population per year, or total 65 cases per 1 lakh population. So it should not be more than this. This target has been set for 2025. This is the elimination target that has been set. And HIV, TB, HIV deaths, this contribution is also high. Around 53,000 HIV, TB deaths occurring every year, and these are the HIV, TB deaths that are occurring every year, 11,000. So now, which are the scientific basis for the treatment? It is important to note that India has been at the forefront of tuberculosis control and its research since the start of 20th century. Whether it is a short course regime, domiciliary treatment for TB, or single-put trial of BCG efficacy, there are mainly 4 scientific bases for tuberculosis treatment. So the first one is the domiciliary treatment. Domiciliary treatment is as effective as sanatorium treatment, and we need not to admit patient, indoor patient, and treat. So patient can be mobile, can go home and come for the medication and again go back to, we are not admitting patient. Then the second basis is this short course chemotherapy. We have very effective bactericidal drugs that, so that we can achieve a more than 90%, more than 85% cure rate, and it also improves the treatment adherence. So we have high cure rates, minimizing relapse and prevent drug resistance with the help of this short course chemotherapy regime. Then directly observed treatment. We are observing patient that patient is taking drug and patient is completing the course, and we are ensuring that patient complete the course and patient become disease free, so he or she may not infect the other. So directly observed means patient call for the medication, and under the supervision of the treatment supervisor or the pharmacist, patient taking medication in his or her presence. Nowadays it is achieved by the video call and 99 dots like technology. So we have also started using the technology to ensure that the patient taking or patient completing the course, and if the patient is missing any dose, then the reminder or the motivation or kind of thing has been given. So directly observed treatment ensure adherence and best possible result, ensure right drug in the right doses at right interval and for the right duration. Treatment regimen. Whatever treatment, whatever drugs we are using, that regimen is as per the bacteriological and pharmacological basis. It is having a strong scientific basis. So what is the bacteriological basis of multi-drug therapy? So there would be appreciable numbers of mutant resistant to any single drug before the start of the treatment. And those resistant mutant will not be killed by the single drug, and they will able to achieve multiplication, multiplying, they are able to survive and capable of multiplying and will not be affected by single drug, and they will continue to multiply. And so the patient will not be cured, and such patient also, there is also risk of transmitting those resistant strain or bacilli to other patient, and this will go on, continue. So by combining the two or more drugs concurrently during the intensive phase, specifically when the bacterial load is high, the chances of survival and selection of drug resistance organism to any drug would be very small, as the mutants resistant to one drug are as a rule susceptible to others. So the one survived by the one drug bacilli would be killed by the other drugs, or if they survive, so then it would be killed by the third drug, because we are combining 3-4 drug for the tuberculosis treatment. So this is very crucial, and this is very important scientific base of the tuberculosis treatment. Then during the intensive phase, we are achieving rapidly killing of actively multiplying bacilli. So during the active phase, our aim is to achieve the patient non-infective. We are making patient non-infective within 1 or 2 weeks. So he or she don't infect the other patient. So this is very important, because the one active case, if you remember, or the one patient during his or her lifetime can transmit 10 to 15 new cases. 10 to 15 new cases. So annually it can infect 15 to 20 patients. Then during the continuation phase, we are ensuring that the elimination of the persisters which are responsible for the relapse. So those bacilli or those bacteria who survived during the intensive phase, naturally during the continuation phase, the load of bacilli or the load of bacteria would be very low, and they are known as the persisters. So this persister would be taken care of during the continuation phase. This is the second basis, or this second argument for the scientific use of the drugs in the treatment of tuberculosis. There are existence of sub-bacillary population. The first group, there are 4 groups, A, B, C, D. The first group A is the extracellular rapidly multiplying organism. So during the intensive phase, the most of the drug act on this group. Then the B group is the extracellular intermittently multiplying bacilli. The third group is intra and extracellular acidic environment slowly multiplying bacilli. And third is the dormant, on which no drugs is active. Now if we look at the actions of the anti-tuberculosis drug on the A group, early bactericidal activity, HRZ, that is isoniazid, rifampicin and pyrazinamide acting on the A group, rapidly multiplying. And in the B group, there is the sterilizers, that is the rifampicin and pyrazinamide. They act on the B group extracellular intermittently multiplying bacteria. And C group, on the C group, the ability to prevent emergence of resistance, the drugs are HRZD that act on this C group and prevent the drug resistance. So the important terminology used here is the bactericidal and sterilizer. So bactericidal drugs are basically drugs which kills the bacteria or the bacilli, and the sterilizer, a term is used for the bactericidal drugs, rifampicin and pyrazinamide, which are called sterilizing drugs as they clear difficult to eradicate forms of pathogen. That is why they are known as sterilizing agent or sterilizer. The pharmacological basis and operational convenience is regarded as the another scientific base, the pharmacological base, to achieve a peak serum level. To kill the bacilli, all the organism, we have to achieve a peak serum levels, and this can be achieved by combining and giving all the drugs simultaneously. So we can achieve a peak serum level, and we can obtain the maximum bactericidal effect. So the chances of relapse are less, but there are chances of adverse drug reaction. So we have to keep balance, we have to aim balance between the relapse and chances of adverse drug reaction. So to strike that balance is very much important, and for that clinical monitoring is the key. Patient has to be called for the follow-up or the treatment supervisor visit, stay in touch, give psychological and other kind of support, which is very given very. So by those support, patients stay motivated and complete the treatment. Now let us look at the certain various definitions that has been used during the tuberculosis treatment or in the program itself. So the case definition, what is the case definition? So case definition on the basis of diagnosis, this is there are four ways to classify the case. There are four ways to classify the cases: as per the diagnosis, according to anatomical site, as per the history of tuberculosis treatment, and as per the drug resistance or sensitive. So let us look first as per the basis of diagnosis. So this is very straightforward. As per the diagnosis, because we have microbiologically confirmed tuberculosis or clinically diagnosed tuberculosis case. So microbiologically confirmed, basically it is a smear positive or culture positive, or it may be positive through the quality assured rapid diagnostic molecular test which are available nowadays. And clinically diagnosed when the result of the culture or smear is not available or inconclusive, and we have to diagnose and we suspect that patient might have tuberculosis clinically, then we can take help of X-ray, histopathology and clinical science to decide that whether the patient is having tuberculosis or not. And this become very complex and very important in case of the pediatric patient, because it is very difficult to diagnose pediatric case of tuberculosis when the sputum is not available, smaller age. In those cases, it becomes very difficult. So we have to suspect that it might be tuberculosis, and we have to look for presence of abnormality consistent with the tuberculosis on the radiography. Importantly, the history of exposure. This is very important, that the history of exposure to an infectious case, which could be any person in the neighborhood, in the family, relatives, or it may be a shopkeeper, it may be from the school, or so the contact history is very important. And if it is present, then we have to be very careful. It could be tuberculosis. Then we can also go for Montauk's test, tuberculosis skin test, which help us to decide whether it is tuberculosis or not, and other clinical findings suggestive of tuberculosis, so that we can rule out whether it is tuberculosis or not. Then on the basis of anatomical site. So this is very simple: pulmonary tuberculosis and extrapulmonary tuberculosis. Pulmonary means when the lung parenchyma or tracheobronchial tree has been involved. Extrapulmonary means other than that, the organs rather than the lungs, like pleura, lymph node, intestine, genitourinary tract, joints and bones, meninges of brain. So these are the things. So again, the severe pulmonary tuberculosis is considered a bilateral disease, or the disease with having a cavity, and the severe extrapulmonary tuberculosis is regarded as the CNS TB or the TB meningitis. This is regarded as the severe. And when miliary TB is diagnosed, it is classified as the pulmonary tuberculosis, because there are lesions in the lungs. And when patient is having the both pulmonary and extrapulmonary tuberculosis, that kind of patient is classified as the pulmonary tuberculosis as per the history. So we can label it as a new case when the patient has never taken treatment, or he or she might have taken treatment less than 1 month. Previously treated, if the patient has taken treatment for more than 1 month from any source in the past. Recurrent TB, TB patient previously declared as successfully treated, cured, treatment completed, and is subsequently found to be microbiologically confirmed TB case. Treatment after failure, those patients who have previously been treated for TB and whose treatment failed at the end of their most recent course of treatment. Treatment after loss to follow-up, a patient who is previously treated for TB for 1 month or more, and was declared lost to follow-up in their most recent course of treatment and subsequently found microbiologically confirmed TB case. Other previously treated is the group in which, if we are not able to classify as per the previous group, then we put we keep those patients in that group, other previously treated group, on the basis of drug resistance. So either the bacilli are sensitive or they may be resistant. So if the resistance is present or detected, then it can be classified as per the how many drugs, which drug is found resistance. So first is the mono resistance, MR, when the one first line anti-tuberculosis drug is resistant. So for example, H mono means resistance to isoniazid. Then polydrug resistance, when more than one first line anti-TB drugs resistance other than both H and R. Because if they both H and R resistance, then it is multi-drug resistance. So polydrug resistance means more than one first line anti-TB drug, but not both H and R. So it could be H and ethambutol or H and pyrazinamide, like that. Multi-drug resistance, MDR, when isoniazid and rifampicin is resistance plus or other first line drugs, then it is considered MDR. Then pre-XDR, when isoniazid and rifampicin resistant plus fluoroquinolone is resistance, it is known as the pre-XDR. Then extensive drug resistance tuberculosis, XDR, when isoniazid, rifampicin plus fluoroquinolone plus linezolid or bedaquiline, that is the group A drug, then it is considered as the XDR. Then rifampicin resistance, RR, when rifampicin plus other anti-TB drugs but not to INH. So it is important to note that when we have rifampicin resistance, it is managed or it should be treated as per the MDR TB case. So which are the treatment regime for the drug sensitive tuberculosis? Whether it is a private or whether it is a government setup, each and every clinician should follow the standards for TB care in India STCI guideline. And the principle of treatment for tuberculosis, other than the confirmed drug resistance form of tuberculosis, is to administer daily fixed dose combinations, first line anti-tuberculosis drugs with the appropriate weight pain. So daily fixed dose combination, first line anti-TB drug and appropriate weight pains. For patients being treated in private sectors, the dose and the other things would be provided by the government or the National Tuberculosis Elimination Program. So it is as per the program. So drug sensitive tuberculosis, intensive phase and continuation phase. So new or previously treated cases, HNR sensitive. So in those cases, we are treating it for the 2 months for the intensive phase with the help of HRZD, isoniazid, rifampicin, pyrazinamide, ethambutol, total 56 doses for 8 weeks. And during the continuation phase for 4 months, we are treating with HRE, isoniazid, rifampicin and ethambutol. Total 16 weeks and 112 doses. FDC, fixed dose combinations. So this is the recent advancement in the treatment of tuberculosis. Previously we were giving thrice a week regime, and it is having a separate drugs, separate isoniazid, separate rifampicin, separate pyrazinamide. All the drugs were separate, but now those drugs have been combined and they are known as the fixed dose combinations, and they are given daily. So it contains 2 or more active ingredient in fixed doses and used for particular indication. So intensive phase and continuation phase, adult and pediatric. Pediatric are dispersible tablet. In adult there are 3 kind of FDC. For IP it is a combination of 4 drugs, HRJD, and for continuation phase combination of 3 drug or the 3 ingredient HRE. For pediatric we have combination of 3 drug HRZ, and for the continuation phase we have 2 drug. And remember that in pediatric ethambutol is given as a loose drug to monitor the ocular side effect. So it is not combined as the FDC, it is given as a loose drug. Loose drugs could be used as a substitution in case of adverse drug reaction or with comorbid condition. So loose drugs are also available, but in certain situation, like in case of development of drug reaction, so we can change or we can monitor that which drug is responsible, and comorbid condition where the few drugs are recommended and the other drugs could not be used. Then steroid can be used as an adjunctive therapy, is useful in specifically when patient is having TB pericarditis and meningeal TB. So whenever it is started, it should be tapered gradually over the period of 6 to 8 weeks. So this is very important that it has to be tapered whenever it is started. So which are the advantage of FDCs? It is simplicity of treatment, very simple because the ingredients are combined. You don't have to worry, simply you have to give according to weight band. Increase patient acceptance, increase health worker compliance, easier drug management, reduce use of monotherapy, lower risk of emergence of drug resistance, and easier to adjust doses by body weight. And you don't need to crush drug, divide doses, and then you have to give because patient is having the lower weight, higher weight. So drug management is also very easy, and reduce use of monotherapy. And patient is not missing any drug because all the ingredients are there. So there are less chances of emergence of drug resistance. So you can pause and you can just observe or study this doses, as adult and pediatric doses of isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Is as per the body weight. Pyrazinamide maximum dose is 2000 milligram in children. So streptomycin is administered only in certain situations like TB meningitis, or if any first line drug need to be replaced due to ADR, in like hepatitis. Like mostly in case of hepatitis, we have to replace the drugs causing hepatitis or suspected to causing hepatitis. Then in case of TB meningitis, where the better penetration of the meninges can be achieved by the use of streptomycin. Ethambutol is given separately for children to monitor ophthalmic side effect. Now this table shows the drug doses for adult drug sensitive tuberculosis. So as per the weight category, we have a intensive and continuation phase FDCs, the number of FDCs. So this is the baseline dose of the one drug, that is in the one FDC, one fixed drug combination drug. So for 25 to 34 kg, you have to give a 2 tablet, 3 tablet in 35 to 49, and so on. So more than 75 kg, you have to give a 6 tablet. Similarly, number of tablet during the continuation phase. and this all tablet contain the all these 4 ingredients. Remember that. So during the treatment, if the weight of the patient increase, suppose patient may gain weight and change from the one weight band to other. For example, this fellow may gain weight and now he or she is considered in the 50 to 64 kg weight band. So this is very convenient for the healthcare worker also, and as a program also, that we can change to this weight band and we can give them 4 tablet. So previously he was taking 3 tablet, now he or she has to take 4 tablet. Drug dose is for pediatric tablet. All adolescents up to 18 years of age and weighing less than 39 kg are to be treated using pediatric weight bands, and children weighing more than 39 kg with adult weight. So if the weight is more than 39 kg, then it has to be treated as per the adult weight band. The key product information for pediatric dispersible tablet, and the tablets are flavored, so children will like to take it. So rifampicin, isoniazid, pyrazinamide, and rifampicin 75 mg, isoniazid. So these 2 kind of FDC is available. This is the baseline dose per tablet. It is dispersible, means it is easily dissolved. Loose drugs, ethambutol 100 mg and isoniazid given separately, because children are having the chances of ethambutol side effect, that is the ophthalmic neuritis, and isoniazid peripheral neuritis. So these are the drug doses or the number of tablet that patient has to take during intensive and continuation phase as per the weight bands. This thing is very important. If the patient is in weight band of 25 to 29 kg or in 30 to 39 kg, then the adult FDC, the adult tablet, has to be added. 1 for 25 to 29 and 2 tablet for 30 to 39 kg weight band. So this is the has to be remembered. Change in weight bands has to be effective upon crossing of the weight bands, irrespective of the quantum of weight gain or loss. As I said previously, it has to be changed. Pyridoxine may be given at doses of 10 mg per day to all children receiving INH containing therapy, irrespective of age group, as a prophylactic dose to prevent peripheral neuritis. So this slide shows the how effective or how convenient and how happy our pediatric patients are because of the dispersible tablet flavored. Previously we have to crush it, we have to break it for the appropriate dose, and we have to mix it with something so that the children like to take it. So this is the photograph showing the 4F combination of 4 drug FDC and combination of 3 drug FDC. Treatment initiation. All the diagnosed patients should be initiated on treatment at the Peripheral Health Institute, and MO Peripheral Health Institute should counsel all the TB patients before initiating treatment. Should also take care of the queries of the relatives and the family members, and then he or she should start the treatment. And what counseling includes? So education of the patient and family members. So what counseling includes? It includes education of the patient regarding the mode of transmission, type of disease, how it spread. These are the general aspect of the disease, how dangerous or how severe it is. Then dose schedule and duration of the treatment. Then which are the common side effects which the patient may encounter and how to overcome it. For example, like the nausea, vomiting. So it has to be advised that it has to be taken with the, not taken with the empty stomach, like that. Then the importance of the need for regular treatment and the consequences if the patient take interruptive treatment or skip doses, not take drugs for a while, then what will happen, like drug resistance and the severe disease and kind of thing. Then cough etiquette. This is of paramount importance because during the initial phase, patient is infective and cough is also there. So the cough etiquettes and proper disposal of the sputum, so we can control the airborne infection and we can prevent the transmission of the disease, especially children and the other family members present in the house. We can also encourage him to get all his close contacts, especially household contacts, screened at the earliest for the tuberculosis. Then comes the clinical evaluation, in which we will measure weight, nutritional status, comorbidities, substance abuse. Then we will open treatment card and each patient must be given TB identity card. Plan appropriate treatment adherence and monitoring mechanisms. That is DOTS provider or the treatment supervisor, can be the friend, relatives or nearby health worker or any good Samaritan can become the treatment supervisor or the DOTS provider. Then MO should maintain TB notification register for patient diagnosed in the peripheral health institute and transferred in peripheral health institute. Arrange for public health action for all notified TB patient. NICSI entry has to be done, and because the most of the outcome from starting from the notification to treatment outcome should be from NICSI only. Standards for TB care in India. There are 26 standards addressing diagnosis, treatment, public health actions and social inclusions which every patient should receive irrespective of where he or she is getting treatment from. Now, which are these standards? So, public health action is the heart of standards for TB care in India. Now, which are the public health action? So, the counseling of TB patient and their family members as and when required. First on-site, at-home visit, then universal drug susceptibility testing, then screening for comorbidities, diabetes, HIV, tobacco consumption or any other disease. Treatment adherence, how to achieve treatment adherence, how to give them support so that they adhere to their treatment. Then follow-up care for ensuring successful treatment outcome. Follow-up care. Patient should be continuously followed up and encouraged to complete the treatment for the better outcome. Contact tracing. This is very crucial. More and more, because the case finding is very important, more and more cases we have to find and put them on the treatment. Then tuberculosis preventive treatment. So this is the kind of prophylactic treatment that can be given to contacts or the susceptible patient who may develop tuberculosis preventive treatment. Then the last thing is the direct benefit transfer, that is the monetary incentive that is given to patient for the nutritive diet and taking care of his or her nutrition. So when the patient is identified positive for tuberculosis or drug resistance tuberculosis, we have a public health actions which includes the NICSI Poshan Yojana. So patient get 500 rupees every month to nutritional support through NICSI Poshan Yojana. Then comorbidity testing, patient counseling, contact tracing, then adherence support through regular follow-up and digital adherence technology we are also using like 99 dots. Then medication event reminder monitor. So what is MERM? It is a medication event reminder monitor and we want successful treatment outcome. Treatment support plan. We have to consider patient as a VIP, very important patient of our system, and we have to do first initial and frequent follow-up counseling of the patient and the family members supervision of the treatment by trained treatment supporter, health worker, family member, community, volunteer. Locally manage additional nutritional support if he or she can get from the local community, from the NGO, because nutrition is of very much important so that patient can tolerate drug, patient have compliance, and ultimately patient cured of the disease without relapse and without drug resistance. Retrieval of the treatment interrupters, screening for adverse reactions, psychosocial support. Patient might get depressed. So this can be achieved by continuous follow-up support, multiple visit, home visit by the friends, neighbor. So this here comes the role of the treatment supervisor. Very crucial. Continuously providing support that you are getting better and better and you are going to achieve the complete cure by the end of the treatment. Comorbidity management, if the patient is having any comorbidity like HIV, HIV, diabetes, if the patient is having HIV, consistent and continuous treatment support from the HIV program. So continuous antiretroviral therapy should be available without any interruption, and follow-up laboratory investigation as and when required, and long-term follow-up. So these are the treatment support plan. It's very much important. Without this will lead to relapse and drug resistance. DOT and DAT. So direct observed treatment and digital adherence technology. So before the digital adherence technology adoption, we have a direct observed treatment. So patients were coming to during the intensive phase, patients were visiting the health facility in presence of the pharmacist or any other responsible person. They are consuming the drug and then they are going back thrice a week. Now we have adopted various technology, so we can rely, and it is time tested. So first one is the 99 dot, in which when the patient is given drug, patient will consume drug and there will be a code or the number which has been provided on the black flip. That person has to be dialed, and so the confirmation is registered on the server and it can be monitored later. Then MERM, medication event reminder monitor, and video dot. This is a newer initiative. This is a kind of video call, and on the video call patient is taking medication. So these are some newer and innovative approach that has been taken to increase drug adherence as well as ensuring that the patient is consuming drug. Adverse drug reaction to first line drug. Now which are the ADRS? There are several reactions which can happen with the use of tuberculosis. We would be discussing mainly the common. You can pause and study the all other side effects. So with the isoniazid, the most common side effect is peripheral neuropathy, but skin rashes may occur, and the hepatitis. So peripheral neuropathy, skin rash and hepatitis, this is very important and serious. Then it is also with the FM patient, hepatitis, and the gastric trouble, nausea, vomiting, abdominal pain. It can lead to generalized cutaneous reactions, thrombocytopenic purpura, and with the pyrazinamide, important is arthalgia and hepatitis, but gastrointestinal effect can also occur. And with the ethambutol, retroverbal neuritis, and specifically important while treating with ethambutol. This is very important when dealing with the children. Now, how will you manage? Because it is very crucial that we have to continue treatment without interruption, otherwise there will be relapse or drug resistance. So how the cases of ADRS has to be managed? What should be done? So the dose of the drug should be checked first, whether you have given an adequate dose, whether it is not a overdose, the reaction is not because of the high dose. So first, to ensure that the appropriate dose as per the weight band has been given, Then second thing is the all other cause of symptoms should be excluded. So if in case there are other causes, then it should be excluded. It can be drug or the disease. Then what is the seriousness, whether it is mild trivial symptoms, signs, or it is a really severe uh, reaction like the anaphylactic or the mucosal involvement or the severe skin rashes or jaundice, then it has to be, we have to act accordingly. The adverse effects should be registered. Each and every reaction should be registered. The drug may need to be stopped and should be eventually be reintroduced gradually when symptoms disappear one by one. So development of drug resistance should be avoided in any case, because we are having very limited drugs, and if those drugs got resistance, then we have to choose another drug resistance regime which is having a longer duration, as well as the drug toxicity is also increased. How to manage? So if the patient is having gastrointestinal side effect like vomiting, epigastric discomfort, it could be because of the any drug, any medication. So give drugs with less water and over a longer period of time, like patient is consuming 4 to 5 tablet or 4 to 6 tablet, then he or she can take it over 20 minutes. Do not give drugs on an empty stomach. This is very important. If the above things fails, then the health worker has to send patient to the MO. A patient medical officer can start with the so medical officer can advise maintenance of appropriate hydration, and he or she can give antiemetics like domperidone and antacid like proton pump inhibitor, omeprazole, etc. Itching, rashes, most probably it is due to isoniazid. Reassure patient, and if it is not severe, it will go off easily eventually. If it is severe, then it has to be referred to medical officer, and medical officer will assess the patient for the rashes and itching. If it is a mild itching and without rashes or mild rash, then treatment can be continued and antihistaminic like cetirizine or other antihistaminic can be given. But if itching is moderate and severe rash, then we have to stop all the drugs till the symptoms subside, and we have to treat patient with the antihistamine. If the patient is having the mucosal involvement, fever, hypertension, like kind of reaction, then it has to be treated with corticosteroid. When reaction subside, reintroduce drugs one by one. Like first we have to introduce INH, then rifampicin, then pyrazinamide, ethambutol in this order. Reintroduce each drug in a small dose. We have to start with the small dose and gradually we have to increase the dose over the period of 3 days. Tingling, burning, numbness because of the isoniazid, and the medical officer can give 100 milligram dose of pyridoxine orally or parenterally until how long? Until symptoms subside. Patient not responding to pyridoxine can be given amitriptyline. Joint pains by pyrazinamide. Reassure that it is the self-limiting condition. If it is not severe, encourage patient take maximum or more and more liquids, maintain good hydration, and if patient is still complaining and it is severe, then medical officer has to come in picture. So MO will give paracetamol, aspirin, and in case of severe disease, indomethacin for week or 10 days. So as per the week or 10 days, it should subside if it is not severe. But in case of severe joint involvement, swelling, inflammation, serum uric acid has to be checked, assessed, and if it is high, significantly high, then we have to start NSAID plus colchicine, because allopurinol is not effective in severe cases. And we have to also consider reduction of the dose of the pyrazinamide. Impaired vision because of the ethambutol. Stop ethambutol, refer patient for the further assessment, refer ophthalmologist for the evaluation, detailed evaluation. Impaired vision may within a few weeks or may not return to normal after stopping ethambutol. Don't restart ethambutol. So this is a kind of serious side effect. Ringing in the ear, loss of hearing, dizziness, and loss of balance because of the streptomycin, middle ear toxicity. Stop streptomycin, refer patient for the evaluation. Refer patient to otorhinolaryngologist for the further reference. As the hearing loss is usually not reversible, do not restart streptomycin. Hepatitis, anorexia, nausea, vomiting, jaundice. So when hepatitis occur, and it may be because of the multiple drug, it may be because of the isoniazid, rifampicin or pyrazinamide, we have to stop all anti-TB drugs and we have to further assess patient, and we have to stop the drugs till the disappearance of the all symptoms of hepatitis. Do not restart treatment till symptoms resolve and liver enzymes return to baseline levels. If the liver enzymes cannot be performed, wait for 2 weeks after jaundice has disappeared to restart treatment. So the signs of the jaundice. So signs of jaundice disappear, and after that 2 weeks period, we have to restart treatment. Restart treatment with one drug at a time, starting with rifampicin, isoniazid, pyrazinamide. In patients with severe disease in whom treatment cannot be stopped, remember, when we are not able to stop treatment, then we have to find the alternatives, like we have to add the other non-hepatotoxic regimen consisting of streptomycin and ethambutol. Treatment outcome. The treatment outcome has to be recorded on treatment card, NICSI, and in the TB notification register within 1 month of event. Within 1 month. Declaration of treatment outcome has to be decided upon and signed with the date by medical officer. When you will label patient as a cured, when patient take treatment and patient is microbiologically confirmed TB patient at the beginning of the treatment who was smear or culture negative, at the end of complete treatment, patient declared cured. Treatment completed when TB patient who has completed treatment, the all prescribed schedule for the duration without evidence of failure or clinical deterioration, but with no record to show that the smear or culture result of bacteriological but with no record to show that the smear or culture results of biological specimen in the last month of treatment was negative, because either because the test was not done yet or because the results are unavailable. Failure. A TB patient whose biological specimen is positive by smear or culture at the end of treatment is considered as the failure. Loss to follow-up. A TB patient whose treatment was interrupted continuously for 1 month or more. Remember, 1 month or more, then that patient is considered as a loss to follow. Not evaluated. A TB patient not evaluated. A TB patient for whom no treatment outcome is assigned. This includes former transfer out. Treatment regimen change. A TB patient who is on first line regimen and has diagnosed as having drug resistant tuberculosis and switch over to drug resistant TB regimen prior to being declared as fit. Die. A patient who has died during the course of anti-TB treatment. This is the treatment card. So this is about the tuberculosis treatment and some minor updates. So it is very crucial that as a healthcare personnel, we care about the how to diagnose TB, how to suspect TB, and putting the patient on the anti-tuberculosis drug treatment. And that is how we can achieve the interruption of the transmission of the infection, as well as we can prevent relapse and we can prevent the drug resistance. In the next part, we will be talking about the drug resistance tuberculosis and how to treat, which are the updates. Hope you enjoyed this video. See you in the next video really very soon. Thank you.